We'll talk about the epidemiology of dementia in India. It's very poignant for me to be standing here almost 20 years later, because almost 20 years ago, more than 20 years ago, in 1998, was when Jacob Roy and I organized the ADI conference in Cochin, at which many of us from NIMHANS came, and we decided to help him on with it. It is also there that the 1066 Dementia Research Group was born. And so to many of us like Shahji and Chandrasekhar and many people who did work from the days from 1998 onwards, it's really very interesting that when there was nothing much available in 98 as far as Indian and Lamic region research was concerned, a group of us sort of went through with the help of Martin Prince to try and offset this balance. So in this paper that we wrote in 2000 in the International Journal of Geriatric Psychiatry, we spoke about how, when you looked at the research, we found that the number of people in China and India would actually exceed the rest of the population in terms of the world's population, in terms of number of cases of dementia that we would have. In 1990, when there was about 3 million and 1.8 million in China and India respectively, by next year, we predicted that there would be a huge increase of 6.4 million and 3.7 million. And we know now that the estimates are very, very low, because we've already exceeded that. We did 3.7 million in India in 2010 when we did the Dementia India report. So we've actually gone way beyond that because of a burgeoning population. So that would be more than the so China and India together, or even alone, would account for more than all the developed economies together in terms of number of people with dementia. So when you looked at the prevalence figures in many of the developing world, whether it was in India, many studies from India, some studies from China, Shanghai, Beijing, we found that the prevalence of dementia was much lower. And so to look at this problem of why the prevalence of dementia was lower, we asked certain questions. So is it because, do we have a low prevalence because of shorter survival? Is it because of cultural and other factors which lead us to under-ascertainment of these patients? Or is there really a difference which is true incidence difference? So, as you heard from the earlier talks, it could be, of course, genes, which we all know support whether somebody will get dementia or not. Could be various environmental and other factors. What we are now talking about in terms of toxins, in terms of diet, in terms of lifestyle. And of course, there is this huge causative factor in many of the polygenic diseases, where it's an interaction between nature and nurture. So there was a real problem about challenges in assessment, because in many of the developing countries there was no normative data about older people, and age ascertainment was very difficult. If you ask most of the older people from villages in India how old they are, they'll all say 70, however old they are. There are multiple languages, so assessments was a problem. And other impairments like vision, hearing make it different. And cultural differences in doing ADL and IADL in different communities make it difficult to ascertain whether somebody is disabled or not. And so we said that we need to have some studies which will take care of this low education and illiteracy and cultural aspects. So we said that specialized instruments should be required. To give an example, when we did the pilot studies in the 2000s, early 2000s, we found that even normal people, higher education normal people and low education normal people were not able to give the correct year. Even now in the LASI study that we are completing, there are many people who are illiterate who cannot tell you which year it is, or even the month or the date. If you ask people to name a political leader, which is part of many of the cognitive questions, you will find places like China and Cuba, they could easily, even people with dementia could easily name, because there's only one leader in those places in those days. But even educated people from Goa could not name the leader because we have so many changing leaders. This doesn't work. Can I change it on that? Can I ask you to change? That's better. Go back. Some more. Yeah, okay. So this is a study which looked at the other issue, not just assessment, but to look at diagnostic criteria which are used all over the world. It was accepted that we use the DSM-4 criteria all over the world to diagnose dementia. And there was this study which is done by the 1066 in many continents in the developing countries showed that maybe it's a DSM-4 which gives low prevalence rates. Next slide, please. Because if you look at the diagnostic criteria used with the 1066 diagnostic criteria and also the DSM-4, you will see that DSM-4 dementias were much, much lower in many of the developing countries than the 1066 algorithm. And the reason for that, next slide, is because the DSM-4 used this parameter of disturbance in executive functioning. And you know that many of elders in our countries are not expected to do anything. So it's very difficult to find out that they have an IADL or an executive function deficits. So the significant impairment in social and occupational functioning, there is a decline from a prior level of functioning, was very difficult to find. So many people would not get picked up as having dementia. Next. But with the new DSM-5, of which Mary Ganguly was a very strong sort of part of the decision-making body, you find that the stance has changed a bit, and so maybe the new DSM-5 is a good way of ascertaining whether there is independence in everyday activities, because independence in everyday activities is something that we expect elders to anyway have. So that might actually tell us whether somebody is getting dependent or not. And so in the LASI study that we are doing all over India, you find that if you use parameters which look at daily functioning in the house, it is probably easier to pick up people with dementia much early than with DSM-4 criteria. Next. What about usage of healthcare services? In India, as opposed to places like China, most of dementia care is managed by private healthcare, or there are hardly any services available for people with dementia. Of course, in a place like China, more than 60% of the population is covered because of a very good public health system. Next. So, way back, the World Alzheimer Report was launched, which actually highlighted for the ADI and the world what a big problem this dementia was. Next. And so, go ahead, next. So, the estimates that were made was much higher than a Lancet article that came, and that it proposed that in 2020, there would actually be more than 48 million people all over the world who have dementia. Next. So, it was Jacob Roy's sort of push and vision that actually made us, a few of us, to get together and write this report, which is the Dementia India report, with help from people like Shaji, Srikala, Jyoti Suran and other people. We looked at meta-analytical studies of different studies that were published in the Indian continent. Next. So, just go back. So, in that study, what we actually said is that, what we concluded is that in 2010, there were more than 3.7 million people with dementia in India, which would actually double every 20 years. And though the numbers are doubling, the cost would actually increase, cost of care for dementia would actually increase threefold. And that families were indeed even now the main caregivers of people with dementia. Next. So looking at the estimates of number of people with dementia in 2010, next please. We actually surveyed about 8 or 9 very good studies out of the many that were done, looking at the epidemiology of dementia. And from all this, we came out with an analytical figure of about a 3.7% of elderly who have dementia at the age of, over the age of 65. Next, please. So with this, we looked at the prevalence, and then of course it is still lower than, as the former speaker said, it is much lower than the Western figures of prevalence, which is upwards of 10%. All the figures in the country was the lowest was in Balabgarh, which is less than 1%. To the highest in Kerala. There were 2 studies done in Kerala by S. Shaji. Those were about 3.74 million, 4%. And if you use the 1066 figures in the Vellore and Chennai study, it would climb up almost to about 10%. Next, please. So the new estimates that we made for India was that we had 3.7 million people in 2010, and in just about 10 years' time, we'll have 6.4. But I'll show you a little later how the World Alzheimer report, which came out a couple of years ago, shows that we already have upwards of almost 6 million people. Next. Now, because of the aging population, the number of people with dementia over the age of 60 would actually double purely because of our population, which was now young or middle-aged and would go on to live much longer. As all of you know, the longevity has gone up and people are now living beyond 70, 80 years. And so that's the reason why this exponential increase in numbers will happen. Next. There will be more women who have dementia, because not just because there's a difference in the incidence between men and women, but it's just that women live much longer and grow much older. Men usually die much earlier. And so you will find that in the age groups of 80 plus and 90 plus, you will actually have more than 15 or 30 or 40% of people who actually have dementia, if you look at number of people in that age. Next. And of course, you can see that this from 2020, which is next year, there will be a burgeoning for the next 30 years, a very rapid increase of the 80 to 90 population, 90 plus population. And so above ages above 75 to 100 will actually go up much more. Next. And if you look at the states of India, this is based on the earlier census projections from the 1991 census, because 2001 census, because the report was done before the 2011 census. You will see that many of the southern states, because people have already become aged and the number of younger people is less, the percentage increase will not be so much. There will be only about less than 150% increase in the southern states. But you will see in many of the northern states, and especially some of the eastern states, there will be a more than 150% or a 200% increase in the number of people with dementia. So the northern states, the middle states, and the eastern states are the real states where we'll have a real serious problem for people with dementia. Next. Now, what is the impact on dementia on family and society? So, because caregivers are existing in the family, you can see that once people have moderate or severe dementia, most people require much care. Almost 80% of the time is spent in caring for these people with dementia, and many, many hours per week. And if you see this figures from the 1066 study, the care that is provided in urban centers was probably needed more care than in the rural centers, purely because the families was much smaller. Next slide. So dementia was not recognized as an illness. It was seen as normal aging, and that's true even for many parts of the Western world also. Health providers were not aware of or nor were they equipped to deal with dementia. Family members and non-formal caregivers are the main people who are facing the difficulties. And caregivers faced a very high degree of stress, and in our studies, over 40 to 50% of the caregivers had either anxiety or depression. And of course, because of this, because of all these difficulties, many elders are susceptible to neglect and abuse. Next. So if you look at who are the caregivers, you'll find that all over the world, it's mainly women who do the caregiving. And in many of our clinics, we are seeing that now people who come to us from cities are actually spouses of people who have got dementia. So it's the other the man or the woman who's grown old with this person who's got dementia, who's now caring for that person. So it's two elders in the house, one of them who's got dementia. Sometimes it's the children, but many of them employ sort of non-formal paid caregivers. Next. Next, please. Again, from many studies, you can see that if there is, this is a graph between number of people in a household. So you can see 2 people, 4 people, 6 people, and so on. And you see that as the number of people become more than 3 people in a household, the burden of caring for dementia comes lower. And that's probably because there are many more people in the house who can take care of the caregiving roles. So in a village where there's an extended or a joint family, it's probably much easier to look after somebody with dementia than in a city where there's just 2 people living in a house or just 1 person living in a house. Next. What about societal costs? We calculated the costs for dementia, and then you'll find even in the report that is released today, you'll find some of the studies from which I've looked at costs from my colleagues, Dr. Girish and Dr. Srikala. And you will find that informal care costs are more than half, more than 56% is accounted for by informal care costs. Direct social and medical costs account only for about 15 and 29%. So it's the huge cost is really indirect rather than direct costs. Next. What about services in India? When we did the report in 2010, something has changed in the last, say, 10 years or so, but really not much. Because of the government initiatives, there are probably now geriatric clinics and geriatric outpatients in many of the big centers in all over the country. That's a mandate for the government because of the national program for the healthcare of the elderly. So there are many more urban centers, not so much in the rural areas. There are very few old age homes. There are many in places like Kerala and Bangalore, hardly any in the north. Daycare centers are very few. I think Cochin is one of the first daycare centers for people with dementia. Caregiver training and support is extremely poor. And there are some senior citizens fora which have burgeoned and increased, which is a good thing, and because there's some support. Next. The newer studies, there are about 4 or 5, and a few more reviewed by Sudhir and others in the report that has come out. Again, does not upset this meta-analytical figures that we looked at. So we are still looking at a figure between 3.5 and 4% of the population who have got dementia in people who are older than 60. So the studies that are done from Kashmir, newer study that is done on the model of the 1066 in Pune, and the Calcutta study, which is a repeat of the old study by Banerjee, all of them showed that the figures were in that realm. Next, please. There are very few studies on incidence. There's probably only one good study, which is done by Mathew. It was a follow-up study in Trivandrum, part of the RC chapter, and then also from the Srijit Rathinal Institute. The rates of the incidence rates for our population was quite comparable to the ones from Asia, which is the Japanese, Chinese, and the Taiwan study, and the Kolkata study. So our incidence rates are quite similar in the East compared to those in the West. In the West, the incidence is much higher than this. But in some countries which have adopted some lifestyle changes, like the Swedish countries, the incidence seems to be coming down. And I'll allude to this a little later. Next. Next, please. Other demographics. The mean age of presentation to the clinic seems to be about 10 years earlier than what they see in the West. So in many of the clinics, the age of presentation is about 63.3 years on a mean. And they usually come in a moderate to severe stage. So they come a decade earlier compared to a higher income country, because in a higher income country they would come in their 70s or 80s. There's something called early onset dementia, which is dementia occurring before the age of 65. The majority of them do turn out to be Alzheimer's, but the important finding here in India is that about almost 50% of early onset dementia presents to the clinic. Of all the dementias, about 50% is early onset dementia. So that's a surprising finding. This is quite different from the Western figures, which is anything from 7 to 30%. Only about 7 to 30% is early onset dementia. So there's something happening which makes our people get dementia probably earlier, even though it's Alzheimer's. The mortality is correlated directly with the severity of cognitive dysfunction. So people who've progressed much faster into moderate to severe stages, they die faster. And this is the death, the mortality is 2.3 times more for elder people with dementia and 2.6 times for people who have got post-stroke dementia. Next. But the types of dementia does not vary compared to all the different dementias all over the world. Some people thought that vascular dementia is much more common in the Southeast Asian countries, and probably it is a little more common in the Japanese population, but newer figures show that it's probably not. Probably a mixed dementia is what is more prevalent, but from clinics you will see that over 60% are Alzheimer's disease, and that 20% is vascular, and the remaining is remaining 30% is basically other dementias. Next. What are the pathways to care? This is a study that we did in Bangalore looking at how people presented to care and to help, and we found 3 different pathways. One is that one pathway is that they go directly and meet the psychiatrist or neurologist when they reach moderate to severe stage, because mainly of behavioral symptoms. Second pathway is that they go to a private practitioner or to general hospital for other physical illnesses, but most of the time the private practitioner or the GP does not detect dementia, and with long and prolonged contact, the physician comes to find out that the person has got dementia. Usually by the time it's too late, and then they get referred to a specialist. And the third pathway, of course, is that it is a very erratic pathway where people move from place to place. Sometimes they go to a faith healer, sometimes they think it's part of aging, and this is a very erratic pathway. The median delay in the pathway is about 15 months, so from the time illness starts, they're usually present much later. They rarely get a confirmed diagnosis from a primary care or a GP. Caregivers are not properly communicated about the illness, so caregivers are quite unhappy, and most caregivers are unsatisfied with the kind of help that they get. Next, please. So this is a report that came out recently. This is again a report which is similar to the 2009 report looking at the incidence, prevalence, incidence, costs and trends. And this actually gave some alarming figures which actually made the WHO and the world sit up and say this is going to be a big problem. Next. So the last few slides which I'll show you are basically slides from many of the ADI reports, which actually tell us what we should be doing now, and that's really the message that I want to convey. So because of the current incidence of 46.8 million in 2015, doubling to almost 74.7 million in 2030, so doubling every 20 years, and by 2050 there will be 131 million people. So because of this prevalence, there is one dementia patient occurring every 3 seconds, and this is going to double. And by 2050, 70% of the people with dementia all over the world will live in countries like China, India, and many of the Islamic regions. Next. But the good story, as you heard from the earlier speakers, is that there's something that can possibly be done to maybe prevent dementia occurring 20, 30 years earlier. And these are the factors that have been found in many of the epidemiological studies that are risk factors. Some of the risk factors are modifiable. For example, vascular disease, hypertension, diabetes, high cholesterol, nutrition, smoking, alcohol, obesity. These are things that you can prevent. There are certain factors that you can't change, like your age. All of us know that every 5 years after the age of 60, your chance of having dementia almost doubles. So age is a definite risk factor. You can't do anything, you have to get old. If you have a family history of dementia, that makes you more susceptible. If you have the ApoE4 gene, that is a little more risk. If you are a woman, you have a much more greater chance of living older and getting dementia. Also, maybe because of your hormones or lack of hormones. If you had depression many times in childhood and early part of life, you have a good chance of having dementia. If you have head trauma, so people who have had head trauma naturally or by playing a sport, they are susceptible to have dementia and other neurodegenerative diseases. Lower literacy is something that has been found to be important. So linguistics and being bilingual is connected to that. And of course, certain mutations, you heard in the morning about presenile1, APP and so on, but you also have mutations on the chromosomes 1, 14, 21, Down syndrome and so on. Next please. There are some protective factors again seen in epidemiology, and we all have seen that active mental faculties, exercise, so-called Mediterranean diet, which looks at olive oil, greens, wine. The estrogen use is still suspect, whether estrogen should be used at all or not in menopausal women. And then of course what is protective can be the ApoE2 allele. But there are things that have been researched all over the world, which is looking at statins, antioxidants, anti-inflammatories, diets and so on. But the evidence for all these in terms of preventing dementia is still questionable. We don't really know. Next please. This is a very nice picture which Clifford Jack drew many years ago, which actually talks about how the initiation of amyloid deposition actually occurs when you are in your 20s and 30s. So maybe preventive measures, which is lifestyle modification, should occur when people are in their 20s, 30s and 40s. Because by the time you reach 50 and you start complaining of memory, there are already molecular and radiological changes and maybe some neuropsychological changes in your brain. And then by the time you're 60, you start getting symptoms, which is mild cognitive impairment. And by the time you make a diagnosis of AD, where treatments are now available, it's already some 20 years too late. Next please. So the intervention programs basically look at reducing this risk. And there's a report that came out in 2014 about reducing the risk for dementia. Next. And so quite recently, the WHO the report on making dementia a public health priority and also looking at prevention talked about treating 5 diseases and treating 5 risk factors. So the diseases are basically the cardiovascular diseases, respiratory diseases, mental diseases, diabetes. And the risk factors was unhealthy diet, tobacco use, harmful use of alcohol, physical inactivity, and air pollution. Next please. And so, can we reduce the risk of dementia? Yes, probably yes, because some of the studies done in the Western world, especially the cardiovascular risk factor studies, have shown that the incidence of dementia is possibly coming down. And so, WHO has actually rolled out in a big way many of these trials. You heard of the finger trial and other trials that are happening, multi-component trials. And so, if you're physically active, if you follow a healthy diet, if you keep challenging your brain, if you have a good social activity, if you look after your heart, and what is good for the heart is really good for the brain is a good adage to follow. Next please. And so the Global Action Plan for the Public Health Response to Dementia, which is what the WHO has pushed in the last few years, we are now in that phase where we are talking about 7 action areas, and this is how we put out the dementia country report last year at the RC conference in Bangalore, which is basically about making dementia a public health priority, increasing awareness and making countries and states dementia friendly, reducing the risk for dementia by reducing all those factors that I talked about, improving the diagnosis and care for dementia, supporting family caregivers and other caregivers, improving the information systems for dementia so that everybody comes to know about it, and increasing money for research and innovation. And this is really something that we need to look forward to, because our country, more than any other country in the world, will have the maximum number of people with dementia in the next few years. Thank you very much.